AETCM, the emergency medicine channel. Shall we start,
Yes.
sir? 18-year-old male, patient presented to ER with alleged history of deliberate self-harm by ingestion of 7 tablets of tab morphine of 10 mg, total 70 mg. On initial 10-second assessment, airway was patent, no pulling of secretions. On coming to breathing, respiratory rate was 18 breaths per minute, SpO2 99% on room air. Air entry was bilaterally equal, no added sounds. Coming to circulation, BP was 137 by 80 mmHg, heart rate 120 per minute. Coming to disability, GCS E4, V5, M6, pupils 2 mm bilaterally equally and reacting. Coming to exposure, temperature was 98.3 Fahrenheit.
What are the problems of morphine toxicity? Do you think that this patient is having clinical toxicity of morphine?
No, sir.
What are the clinical signs of morphine?
Usually, opioids will act on mu receptors, kappa receptors, and delta receptors, which can cause respiratory depression, sedation, analgesics, and it can also cause altered mental status,
First is
hypnotics,
what?
respiratory
You
depression.
give morphine in a patient with cardiac failure, heart attack, no? In MI.
Yes, sir.
What are the things you are worried about? Respiratory depression and all occurs in very high dose. What is the first thing you will notice in that patient? Myocardial infarction, you are giving morphine, 2 milligram, 2 milligram, 2 milligram. What is the first thing you will notice? Then pain relief. What will happen to heart rate?
Vagal stimulation, bradycardia,
Bradycardia. What will happen to BP?
hypertension.
Then only other things will occur. Okay. That sleep will come fast, but heart rate will come down. Hypertension will happen. Then respiratory distress will happen. Okay, that will be the sequence.
But here patient had tachycardia, most probably due to fear or stress.
Fear, nothing. Okay.
Adjuvants to primary survey, we got a VBG done. We got an ABG done. pH was 7.45, BICARB was 23.4, PCO2 38, and PO2 81.5. No acid-base disorders.
Okay.
ECG showed sinus tachycardia.
Okay. So that doesn't correlate with morphine overdose. That is the only issue. Tachycardia may be due to fear. Okay.
Coming to ample history, an 18-year-old male patient came to ER with complaints of alleged history of deliberate self-harm by ingestion of 7 tablets of tab morphine, 10 mg, from his home at 6 p.m. These tablets were given to his father for cancer treatment. Patient was taken to a nearby hospital immediately after this, and they had documented that patient was drowsy and had tachycardia at that point of time. After coming to ER, patient was conscious oriented and was responding well to verbal comments. No history of seizures, abnormal movements or agitation. No history of constipation or urinary retention. No history of ingestion of alcohol or any other drugs with morphine. No history of previous self-harm attempts. Spontaneous breath counts and GCS was monitored every 2 hours, and both of which remained normal for 1 day observation. And we had same toxicology level also. And since patient was symptomatically okay, we had discharged the patient.
Okay. So what treatments you can give if the patient come with morphine toxicity, morphine overdose toxicity? What all things you will take care?
Initially, supportive management is more important because most morbidity occurs due to respiratory depression.
Okay.
So either we have to initiate on oxygen, or if required, we have to intubate the patient.
Okay.
If the patient comes with severe respiratory distress or leading to apnea or cyanosis and all, we have to immediately give naloxone.
Okay.
2 milligram has to be given in such patients presenting with apnea or cyanosis. Or if the patient is not on is not opioid dependent patient, then we can initiate on 0.4 milligrams of naloxone IV, which can be given every 3 to 5 minutes till all the symptoms are reversed.
Okay.
Supportive measure, and if the patient is having pain, we have to give analgesics.
Pain with the
No, sir.
morphine will not cause pain.
Pain.
Morphine is given for pain, and if you ask this patient had there was no pain, nothing was there. He was very happy. Was not even drowsy. Okay.
And if the patient is on long-term opioid, and then we have to give, after giving naloxone, additional treatment, you have to give naltrexone, which is also an opioid antagonist, which can be given in oral form, because naloxone's oral availability is very poor.
Okay.
These opioids refers to broadly to all the components related to opium that possess analgesics and sedative properties. Opioids describes the alkaloids codeine and morphine, which are found naturally in the opium plant. But narcotics refers to a broader group of drugs predominantly used by law to refer to a controlled substances with abuse or addictive potential. Pharmacology, these opioids are nociception at the terminals of afferent nerves, especially in the CNS and peripheral nerves, and also in GI tract. So these acts on, like I told before, mu receptors, kappa receptors, and delta receptors, which produces analgesia, sedation, meiosis, respiratory depression, cough suppression, GI motility will be decreased. Okay. Same with kappa receptors also, but weaker analgesia. When it comes to delta receptors, mostly it causes antidepressant effects. These opiates can be classified into naturally occurring, that is opiates, codeine, morphine, and our patient had taken morphine. Then chemical modification of natural components, semi-synthetic drugs like buprenorphine, hydrocodone,
buprenorphine, where it is useful in clinical practice?
Buprenorphine patches can be used
patches,
for...
it is available as patches. Okay. So that can be given for patients with chronic pain.
Synthetic derivatives like fentanyl also can be used as a patch.
So in myocardial infarction, if morphine is contraindicated, can you give fentanyl?
Yes.
So one of the drug indicated is fentanyl. HA is not.
Now new recommendation.
It is already recommended drug. Okay.
Coming to pharmacokinetics, they're readily observed and will reach the peak levels within 30 to 60 minutes after the ingestion of standard formulation. But what happens is in patients who are drug misusing, then they can take unconventional route of administration, like they can ground the opioid tablets and then take as an IV, or they can heat the fentanyl patches, and this can alter the pharmacokinetics of opioid absorption. In opioid intoxication, the toxidrome includes meiosis and lethargy, respiratory repression. So our diagnosis is mostly clinical. If we find this meiosis, respiratory repression, and lethargy, then we'll have to suspect morphine poisoning. Also, other symptoms includes orthostatic hypotension, nausea, vomiting. Histamine release can cause, which can cause localized urticaria. Then also ileus due to reduced GI motility. Depression in mental status. Sometimes in severe cases can cause cerebral hypoxia. And sometimes this opioid can also cause acute liver injury. So we'll have to auscultate for any CREPS. This is mainly due to...
Auscultate for CREPS? Liver injury?
No, not liver injury, lung injuries.
It is very rare.
Very rare. But because of hypoxic induced alveolar injury, this can happen. Or because of this histamine release, there can be cutaneous vasodilation that also can cause to it.
Okay.
But very rare, like you told. Then diagnosis mainly with the triad of lethargy, meiosis, and respiratory repression. Physical examination, we have to look for any injection.
What are the other causes for pinpoint people? One is morphine. This is a very important observation in emergency room. IC bleed.
Opioid poisoning. Clonidine poisoning.
I don't know. Clonidine, does it produce?
Yes, sir. Clonidine poisoning also.
Okay. Which IC bleed will produce pinpoint people?
SH.
Fontaine hemorrhage.
Fontaine hemorrhage.
Okay.
Opioid poisoning also.
So these are called as toxidromes. When you get a patient with certain findings, a group of findings, you can make a probable diagnosis. Okay. Toxidromes.
Here we have DDs which include clonidine overdose, which has coma, bradycardia, hypotension, meiosis, and periods of apnea. Opioid carbonate poisoning, we have cholinergic toxidrome, meiosis, muscle fasciculation, profuse vomiting, diarrhea, and sweating. Also, if they are taking olanzapine, phenothiazine, and risperidone, also can have a neurological depression and meiosis. Okay. All this has meiosis.
Meiosis, okay.
Then carbon monoxide poisoning also can cause profound depression, but not associated with meiosis.
That produces mydriasis.
Yeah. Other DDs can be hypoglycemia, hypoxia, CNS infection, post-ictal stage after seizures, Fontaine intracranial hemorrhages. Opioids.
You have written it, but you are not telling. You have written everything in book. Okay.
Opioid screening, usually we use urine opioid screening. Confirmation test is either gas chromatography or mass spectrogram, which is not usually.
Which is not.
usually done.
We do urine morphine
Morphine
test.
test. A treatment, like we told, mainly it is supportive.
Okay.
Then naloxone. Naloxone, it is a derivative of oxymorphone, is a pure competitive antagonist of all opioid receptors. So all the side effects of morphine can be reversed by naloxone.
Okay. Is it dialysable?
Naloxone. Morphine.
Morphine?
Not.
It's not dialysable.
Usually we give a 0.4 milligram IV who is a non-opioid dependent patient, until we repeat every 3 to 5 minutes until all the symptoms of opioid is reversed. But in case of cyanosis or acute apnea, then we have to give 2 milligram IV. Maximum 10 milligram can be given in such patients. The duration of action of naloxone mainly depend on the amount of opioids taken by the patient. Continuous infusion is required if the patient has responded to initial bolus. And how to calculate the infusion rate, we have to take 2/3 of the dose per hour IV infusion and then start on infusion. And we'll have to look for adverse effects of naloxone, that is mainly withdrawal symptoms. So if when we start
only
infusion,
patient is on chronically on morphine, if you give naloxone, it will create a issue.
Yes. Other drugs like naltrexone and nalmefene also can be given post naloxone as a withdrawal drug.
Okay. How was the patient after discharge? There was no issue. Should we refer this patient for psychological consultation?
Yes, because it was a deliberate self-harm.
Okay. Is it a police case?
No, sir. No.
Normally,
Suicide is
since
not
it is a suicidal intentional intake, it is not a police case. But if otherwise, recreational means it will become a police case. Okay, that should be clearly demarcated whether it is suicidal intention or recreational use. Recreational use, we have to inform police. Okay, thank you.
Thank you, sir.